This week on Wake Up and Makeup, we are off to Nyanza province to meet two phenomenal women. We find out about their life-changing initiatives that have impacted their communities. What are some of the things that have inspired you to just say, I think as Esther, I'm going to be the first to start to change that? You've been doing such an amazing job with Karen. Please tell us more about her story.
Well, Karen is a widow.
It's not Wake Up and Makeup without a makeover, and I get to spoil my guests with some beauty treatments. You want to be inspired? Well, don't miss this episode of Phenomenal Women only on Wake Up and Makeup.
I do want to have it. I'm excited to be a father again, especially if it's your child.
Darling, there will be time for that.
What a strange thing for your friend to just show up for a visit, right?
You provoked me. I was just defending myself.
You're a hypocrite.
This has never happened here, Katya, never. You brought fiction into this house.
How dare you hit my little girl?
What is it, Dad?
Bad news from Colombia, son.
Kibera is the largest informal urban settlement where most of its residents live close to or below the poverty line. Scrambling over mud puddles, across eavesdrops and train tracks covered in garbage, I followed the direction to get to Atieno's house. I find her lying on her bed. She struggles to hide her pain, but her body structure, however, cannot hide this well. For 9 months, the 30-year-old has never returned to hospital to complete her cancer treatment. She has no money.
I've been having interrupted sessions of chemotherapy because of money. First of all, sometimes if you go to the hospital, there are no medication. You have to buy them. And maybe they are very expensive. Chemo drugs are very expensive. Sometimes you've processed NHIF, NHIF is going to pay for you. When you reach there, you are being told your medication is not available. And you don't have that 7,000 or even 14,000. So I just have to come back home and wait for that money.
Atieno's troubles began in 2016 when she was 5 months pregnant.
I was expecting my third born. When I was 5 months pregnant, I started having severe stomach pains. So I could go to the hospital, but they would relate the pains with the pregnancy.
Atieno had to go for several lab tests from one of the slum hospitals, but unfortunately the results were out as amoeba, typhoid and ulcers.
They would give me medication for typhoid. I would take medication. After some months, the pain recurs again. And the more it comes, the more worse and very painful it will be.
Although Atieno had lots of hurdle in terms of finance, she had to try another hospital where she was referred to. That was Kenyatta National Hospital for advanced scans in 2016.
They sent us to do the colonoscopy, but we couldn't afford because my husband didn't have a job. I was also not working. He had just a papa shop in the slum, so he could not afford 38,000.
Yet the pain was getting more worse.
I was taken back home to go and try with the herbs. Yes, but it didn't work. I was wasted, bedridden, and then I was admitted.
She wasn't capable of passing stool, and the doctors had to take her to the theater to deal with whatever they could find from her stomach.
When I went to pass stool, I could vomit fecal. So when they took me for emergency laparotomy, as they call it, they found out that it was a tumor which had grown into my colon, and it had covered the colon colon 100%.
After her whole journey to the hospital, the doctors found out that she had colon cancer after a colonoscopy test, and the results were positive.
At that point in time, they did not stage it, but doctors said that it was maybe stage 3. She used another term, close to stage 4.
Giving support and paying attention on cancer patients is what Atieno urges the government.
The government, they should make it easy for cancer patients to get their medication. They should not lack those medications, because once you miss chemo, the disease metastasize. People are really dying. You know, you cannot know unless you go to the hospital.
Atieno narrated to me how she really wants to be well because of her young children.
I was left an orphan at a very early age. So I would not like my children also to be raised with another person, because my parents died when I was very young, both of them. So I was praying that God should give me that grace to raise my children, to see them grow old.
This prompted me to call Dr. Nyongesa of Texas Cancer Center to find out if we can get Atieno on medication. And her hope to live in order to be there for her family has just started. At Texas Cancer Center, we are welcomed by Dr. Kanjama. Poverty, according to Dr. Kanjama, makes it difficult for cancer patients from poor neighborhoods to access treatment.
We have like an open door policy, so we offer treatment for cancer to patients like her, needy patients, and other patients.
Most poor people cannot afford treatment in private facilities, which are better equipped. Atieno's case is a perfect example of how poverty-related factors, including unemployment, low socioeconomic level, rural residence, and insufficient access to reproductive health information, led to her colon cancer at a young age.
I've been calling most of my friends. Tunafanya funding kidogo at least to raise pesa ya clinic kama 45,000. Unapata saa zingine imefika, saa zingine haifiki. So inafikanga mahali inakuwa ni kama ni mzigo tena, because the more you call friends wanakuwa wanachoka sana na hizo calls.
Most cancers usually remain undiagnosed and untreated until it has spread to other parts of the body. Poor women are often undernourished, and poor nutrition can also increase reproductive cancer risks. If I get a patient today and a biopsy is done and a month later there is no action, something needs to be done, said Dr. Nyongesa.
Cancer is the third commonest killer in our country. We diagnose about 47,000 new cases and 33,000 die of the cancer. The increase is multifactorial, but we see on majority like 60% of the cancers are occurring in women. So one, just being a woman, we have a higher risk. Older age, use of tobacco, smoking may contribute, but majority of the cancers, the cause is not known.
Well-wishers touched by her story of bravery in the face of death are urging her to continue with the fight. But all that Atieno's husband is holding on is the president's speech of free medical treatment for cancer patients.
Well, a very good evening to you. That is just the story of Anastasia Otieno. That is her battle with cancer, and she will be giving us more details of her journey. She is here with us in studio, so she will be talking to us about the treatment aspect of it and what really she's doing to continue ensuring that she gets treatment, a healthy lifestyle, and of course, nutritious meals. That is a discussion that we will be having this evening here in studio. Our focus of discussion is what has been happening in the country, the current call for, of course, the government to declare cancer a national disaster, what really are the issues. But today on Beyond the Headlines, we want to focus on the preventive bit of it. How do we prevent cancer, given the statistics show at least between 30 to 50% of cancer cases can be prevented? How do we do that? Well, that is a discussion that I will be having. But before I introduce you to the guests in studio who are here this evening to give us more perspective on this, let me quickly take you over to Jane, who is on the other side of the studio, who can give you some of the lines where you can interact with us, share with us your comments, give us your story, and also give us a bit of the statistics of what really are we talking about when we say that cancer is a problem. It is a silent killer, and something needs to be done, and particularly to prevent this. Over to you, Jane. What do the numbers look like this evening?
Well, a warm welcome once again to our viewers. We're glad you are with us this evening. And just as aforementioned, today we're going to be looking at the cancer burden here in Kenya, which is, of course, in line with the national conversation in regard to declaring cancer a national disaster. But first, let's start on a global scale. Let me just give you the stats. Globally speaking, cancer has been termed to cause more deaths than HIV, tuberculosis, and malaria combined. It has caused more deaths than those three combined. It is also said that 70% of the global cancer burden is in low and middle income countries, where at least 1 in every 5 men and 1 in every 6 women gets to suffer from cancer at one point in their lifetime. Now, let's bring the conversation back home. Here in Kenya, cancer has been said to be the third cause of death here in Kenya, which is after infectious diseases and cardiovascular diseases being first and second, respectively. Now, looking at the mortality rate, it currently stands at 7%, which translates to about 36,000 people every year, down to at least 3,000 people every month and 90 people every single day. Among the women, the leading causes of cancer are breast cancer and cervical cancer, and among men, the leading causes are prostate cancer and colorectal cancer. And just looking at the prevalence across the country, there are 11 counties that are heavily affected by cancer, and that specifically is esophagus cancer. Now, the big question that so many of us are asking is, why are so many Kenyans dying of cancer? And it's not just a Kenyan issue, it is a global problem. And so many questions we tend to ask ourselves. Is it the expenses that are involved in the treatment? Or is it the whole issue of misdiagnosis, which consequently leads to the wrong treatment of this cancer? Another question is in regards to facilities. Is it that we have poor facilities or the lack of these facilities, thereof considering there are only 3 functional radiotherapy machines at the Kenyatta National Hospital? Or is it an issue to do with staffing and specialists, considering that there are only 35 oncologists here in Kenya? What do we need to do to put in place preventative measures against cancer so as to avoid a reactive way response to these cases, as opposed to having a proactive way towards dealing with cancer? What preventative measures do we need to put in place when it comes to the fight against cancer? That is a discussion that we are about to have right here on Beyond the Headlines, and we'd love for you to be part of this discussion, and you can do so via our communication platforms. You can also go onto Twitter. The hashtag is right behind me. That is hashtag BTHKBC. Our official station handle ever remains at KBC Television. Our SMS line is up and running. 20154 is the number. Do leave a name and location. And please remember to start your messages with the initials BTH. And of course, we are also live on YouTube. If you need to leave the house, take your phone with you and stream us live on YouTube. What again do we need to do? What preventative measures do we need to put in place in the fight against cancer? That is a conversation that we are about to have, so keep it here. Over to you, Catherine.
Well, thank you, Jane. That is how the numbers look like. But for now, let me introduce you to the guest in studio. Of course, I'll begin with Anastasia, whose story you have just seen a couple of minutes ago. She is a cancer survivor. It's good to have you, Anastasia, in studio.
Thank you.
Well, next to her, we have Dr. Siwiles Mithi, a clinical oncologist. It's good to have you, Dr.
Thank you.
And last, we have with us David Makumi, who is the Vice Chair of the Non-Communicable Diseases Alliance, which is in the civil society. Thank you, David, for joining us this evening.
Thank you.
All right, I want to begin this discussion with you, Anastasia. We've just seen your story. Tell us a little bit about the treatment bit of it. There are a lot of myths and misconceptions of what really happens when it comes to treatment of cancer.
Okay, first of all, I would like to say that the disease itself is not easy, and the treatment also is not easy.
Just speak up a little bit more.
The disease itself is not easy, and as well as the treatment. First, it is very expensive, and most people cannot afford it, and it has a lot of side effects. Yes.
What sort of side effects perhaps did you experience in your case?
Sometimes after chemo, some people lose their hair, sometimes you vomit a lot, sometimes you diarrhea to a point in which you cannot even walk, you cannot move. Yes.
So how did you get through, the treatment? Are you still on treatment as we speak?
Yes, but my treatment has been interrupted a lot because of funds. It's expensive.
So the treatment which I was supposed to get for 6 months, I've done it for 2 years.
For 2 years.
Because I cannot afford it. Yes.
Dr. Siwiles, what really is the situation in terms of, affordability? That is a question that we keep coming back to each and every time.
Yeah, so generally the cost of cancer treatment is expensive. I agree with what she's saying, but then we do have insurance packages like NHIF has really come through for these patients recently. You find that most of the patients are able to access affordable cancer care in both the public and private sector as we speak. And this has really greatly reduced treatment times in terms of waiting times for these patients, because NHIF is able to cover most of the treatment costs at this moment. So previously maybe cost was an issue, but right now I'm sure NHIF is covering for this treatment, and there are even more negotiations that the ministry is going to do with the NHIF to improve the oncology package for these patients. So yes.
David, there are those people who have always said that cancer has become sort of like a business. I mean, what would you say?
Certainly, the costs associated, and in spite of the fact that NHIF is helping our patients, there's still significant out-of-pocket spending. Patients have to pay for tests, for scans, and you might find that when they go to their, maybe to a facility, a public facility, they might find maybe the scanner is not working, or maybe something in the lab is not working, and they are sent outside. So you might find that those kind of perceptions, I would call them perceptions, given that every other person you talk to is either fundraising for cancer or to meet some treatment costs, because inevitably patients have to pay. And maybe what would change that is a situation where NHIF would cover 100%, so that there is not much out-of-pocket spending, and this treatment and test be done, in one center, in the same setting. So then patients don't have to move around to do a scan there, a test over there, and that creates that perception of business. However, there are certainly situations where patients are exploited by unregulated supplements and herbalists and those sort of things. Those ones are in business, because some of those unregulated things are really not helping cancer patients. You get people doing monthly nutrient supplements and so on. There are patients who are also getting exploited by medical tourism. So a patient who won't benefit by being taken overseas, maybe they have very advanced cancer, very, very advanced cancer that whether you go to India or to South Africa or to North America, it won't change the situation. So you might find a patient who probably would have been better off having good supportive and palliative care and treatment over here is being shipped almost when they are gasping. So in that context, then there is need to protect patients from exploitation.
Okay. Perhaps in your experience, what are some of these out-of-cost, expenses that you had to go through? You seem to be agreeing with everything David was saying.
Yes, as fast as I know, as a cancer patient, NHIF covers for 6 cycles only, and sometimes you have to undergo 12 cycles of chemotherapy. So in their financial year, they always cover for 6 cycles of chemotherapy only. For somebody like me, I had to go for 12 cycles. That's why the medication I was supposed to get for 6 months, I'm now getting for 2 years. Yes.
So what is the cost per session?
My cost per session goes for 25,000.
For 25,000.
And I have to do it twice a month. Yes, that is 50,000.
So how have you been able to manage this cost? Have you been, forced to go through Harambes just like David is saying?
In fact, I missed my chemo. It was interrupted a lot, and I had to miss my chemo until one day I became very wasted again. And Jackie, there is this lady who came and helped me. She took me to Texas, and I was given medication for free after I've missed my cycles of chemo. Because I could not afford. Yes.
That brings us to the question, Daktari, how many people are aware of where they can access treatment? Because you see, like she says in her case, she had to go through it, and she went to somewhere where she actually could get treatment for free. But how many Kenyans are aware of where they can get help?
Yeah, actually, I would say that there's a lot of ignorance in the general population. Most people, once diagnosed, are not aware of where they can go and access treatment. And this is because of the scarcity of the cancer treatment facility worldwide. Currently, as we speak, there are 7 county referral hospitals that are offering chemotherapy services. We have the county referral hospital in Meru offering chemotherapy services. Mombasa is offering these services. Kisumu, Kakamega, Nakuru, Nyeri, and Garissa. All these hospitals are offering chemotherapy services. Now, the only hospital offering radiotherapy services on the national scene is, of course, Kenyatta National Hospital, and we have 3 machines. We do not have any county hospital offering radiotherapy services right now, and that is a major shortcoming. And in the private sector, most of the radiotherapy facilities are located within Nairobi, and we have hospitals such as Mpisha Cancer Center that is offering radiotherapy services, the HCG-CCK. We have Nairobi Hospital that is offering radiotherapy services. Aga Khan Hospital is also offering radiotherapy services. So in the public sector, maybe just KNH is serving the whole population right now. But we have those other hospitals in the private sector that I have mentioned, and the other county referral hospitals that I've mentioned that are offering chemotherapy services as well. So,
but if you look at it against the population of Kenya, it's still a problem. No,
it is still a problem, yes. So people think the only area where you can access this treatment is in Nairobi. People are not aware that we have some county referral hospitals that are offering this treatment, which is accessible to them. Because it doesn't make sense for a patient coming from, say, all the way from Lamu to access treatment in Nairobi. Well, they can access the chemotherapy at Mombasa. There's a strategy that the National Cancer Control Program is implementing, and it's hoping to equip 3 more county referral hospitals with radiotherapy services. Mombasa is going to have a radiotherapy unit very soon, Nakuru and Garissa. So you see, that is going to ease the burden on Kenyatta National Hospital, because right now it serves patients from all over the country. And so that is a huge setback as we speak.
Even as she talks about that, the statistics are showing that we don't have enough number of, oncologists.
Yes.
So perhaps how do we overcome that challenge? Because the government is keen on opening, cancer centers in every county, but do we have the personnel to match?
I would say, okay.
No, you can answer, it's fine.
Okay, so before he speaks, I would say that we have made significant progress when it comes to the number of oncologists in Kenya currently. Like she mentioned, your colleague mentioned previously, we have around 35 practicing oncologists currently. We have around 20 in training as we speak. And we've also established local training programs. Nairobi University has launched a radiation oncology program. In September this year, we are going to have the first batch of students going to do their masters in oncology. And previously, like most of us, the 35 of us had to practice, or rather to go and study in countries outside the country because we did not have the training program inside the country. But then right now, I think establishing a local training program is definitely a positive step towards the right direction. So in the near future, maybe in the next 3 to 5 years, we're going to have more than 100 or 150 oncologists, if this is going to be the trend. Yeah.
All right, David, we're talking about cancer and the fact that about 30 to 50% of cancer cases are preventable. Are we putting emphasis on prevention in this country, or we are focusing more on opening cancer centers, radiotherapy, treatment, and nobody's talking about prevention?
I think essentially our approach to cancer, as it were right now, has been more focused and brick and mortar construction of radiotherapy, of cancer centers. But I think we need to look at a comprehensive approach right from prevention, screening, all the way to palliative care and even rehabilitation for people who get treated and have to go back to work. How do they get reintegrated? But talking of prevention and public information and education with accurate information, we have not invested in that area. Incidentally, a lot of the things that are being said about cancer by the politicians and all this, they are all focusing on we need to construct this, that, and the other.
Yes.
That's important. It's also important to develop the human resource capacity that Dr. is talking about. That's critical. But in terms of defining the level of service, because all the centers that we are talking about are almost tertiary. You know, we want to build a center that will do radiotherapy, etc. But we need to define what can we do at community unit level. You know, telling the community, for example, that tobacco is a risk factor for cancer and non-communicable diseases. You don't need an oncologist there, because then the community health workers at community unit, even the chiefs and the assistant chiefs, can be given such basic information on prevention at community unit level. And that information has to be packaged, you know, that it is scientifically sound and accurate, so that they can distribute this information. At dispensary level, what can we do? Doing cervical cancer screening, doing clinical breast examination, telling, giving public information and education. At dispensary level, you don't need an oncologist there. We only need to empower those frontline staff. What else can we do at even at health center level? The primary frontline staff, the doctors and clinical officers and nurses who see patients every day and treat them for diarrhea, for malaria, for everything else, we need to retrain them. We need to change their thinking, get them to have a high suspicion index for cancer. Again, at that level, you don't need an oncologist. You only need a patient who is seeing a doctor or a clinical officer with a patient in front of him, a patient who has come for other services. Maybe they are being treated for scabies. Let that person be taught some basic information. Do you smoke? Do you drink? You know, do you use alcohol? You know, can we check their weight? What is their diet? Do they exercise? Even if they came for other services. And this will help the frontline staff to always constantly think, not just about cancer, but also the entire spectrum of non-communicable diseases at that level. And that is where we are missing it. As a country, where patients present early, patients don't present late. The narrative that our patients present very late is a narrative that has gone on unquestioned. Patients present very early, but they get missed out at that point. And that is where we need to put our money. If I was a governor, I would empower those frontline staff, get screening at that level, mashinani, so that every patient coming, and a mama bringing a baby for chanjo, that mama also needs to be attended. Her health needs to be addressed. But that has to be within a comprehensive national approach, not piecemeal.
Not piecemeal. All right, let's talk about, you know, your situation, Anastasia, and I want to look at it from, you know, the point of stigma. Is that something that you went through? Because many people would have, you know, did you face stigma in your process?
Can I speak in Swahili?
Yeah, sure.
Hapana. Mimi sikupata stigma.
How was your journey? When people found out you were sick, you were bedridden, did you know the cause of what was ailing you, and how did your family take it?
In fact, the person who was so close to me was my husband and my sister-in-law. So, hawakunitenga. They were very supportive, and they are still supporting me.
Let's talk about the symptoms that presented themselves in your case, which is colorectal, you said colorectal cancer. Yes.
Okay. Initially, I started, you know, I was expectant. It all started in 2015 when I was expecting my third child. And I started having these stomach pains. I could go to the hospital and they would relate the pains with the pregnancy. Yes. So after delivering my child in 2016 March, I started experiencing the pains again. And this time it was worse than it was before. So I could go to the hospital, they could diagnose me with the amoeba, typhoid. Even there is this doctor who diagnosed me with the fecal impaction, and I was given Movicol. Yes. So I tried, but it didn't work for me, so I decided to go to the village to try with the herbs, but still did not work. So it reached a point that I could not pass stool, but instead I was vomiting fecal. So when my husband saw my situation, he said, no, this is not normal. I should take you to KNH. So he took me to KNH, and my situation, in my condition, I was wasted. So the doctors decided, the surgeons decided to do the emergency operation because we could not even afford 8,000 for the scans, for the CT scans, and I was vomiting fecal. So they decided to help me. They took me for an emergency operation, and when they opened me up, they found a tumor which had blocked my colon 100%. Yes, that's how it was.
It brings us back, to the question of misdiagnosis and, where do we access, some of the services. In terms of screening, where can we get, what are some of the centers where we can go to?
Okay. So currently, as we speak, all county referral hospitals have been equipped with the necessary facilities to carry out cancer screening. And this has been made possible by the National Cancer Control Program of 2017 to 2022, and they've established national cancer screening guidelines. They were launched in February 4th, that was World Cancer Day in Meru County, with an aim of trying to standardize screening and provide information or know-how on how to do screening for screenable cancers. When I'm talking about screenable cancers, I'm talking about cancers like breast cancer, cancer of the uterine cervix, oral cancer, colorectal cancer. So with this aim, the National Cancer Control Strategy decided to launch those screening guidelines in Kenya. And since February 2019, these guidelines have been disseminated to all the counties. Dissemination was concluded in Coast Province, Mombasa County, in this past week. So I can very confidently say that these guidelines have already been disseminated in the counties all over the country. So it is now the task of the counties to now disseminate and implement these guidelines, screening guidelines within their counties. So you can go to any county referral hospital right now and get screened for the cancers that are amenable to screening. Remember, not all cancers are screenable. We have those which are amenable to screening. So you can get those facilities in any county referral hospital right now.
Is it for free, the screening in the county hospitals, or you have to pay something?
Okay, I may not be able to talk about the cost, but maybe that is something I may have to confirm. But you see, something like mammogram for breast cancer screening, say in my county where I practice in Muranga County, a mammogram costs 1,000 shillings, and NHIF doesn't cover for it. So patient has to pay out of their pocket to have that test done. And that is one of the issues that could be hindering people to go for this screening. Because of course there's the issue of lack of awareness, but then there's the issue of cost. Because if I have to go to the hospital, then pay 1,000 shillings for me to just have a mammogram done, then that is discouraging, you understand? For pap smears, a pap smear is relatively expensive, okay? So if you tell a patient that I need you to get screened, but when they get to the facility, they're told, okay, you need to pay this much for this test, then of course that is a hindering factor. So with the costing issues right now, maybe it's something we need to look at. Yeah, something we need to look at, maybe include it in an NHIF package, or the National Cancer, the Ministry of Health can make the whole screening process free. I think that would be a good thing, so that we encourage people to get screened, and in this way we can detect these cancers when they are still early, and appropriate interventions instituted before the cancer gets advanced.
All right. Do you see us getting to a point where we'll be talking about free cancer treatment? Because the argument has always been, like you said, you have to go to the lab, you have to, there's a whole journey before you actually even get to find out what is ailing you.
Yeah, so, but essentially, maybe first to pick it up from the aspect of screening, because that is primarily targeting people who are not sick.
Yes.
And that is where NHIF should come in, because there is always some kind of payments for the screening. So if we started there and tell Kenyans, look, you got NHIF, you can go get screened. That's the kind of pronouncement that would help us, even as we move towards figuring out, so cancer treatment, should it be free? There's nothing that is free. There's no free lunch, as it were. Someone will pick up the bill, So the question is it within the NHIF UHC framework that the treatment will be availed at no cost to the patients, so that patients will be registered into the UHC and NHIF. So that's where, those are the agencies that you pick up the tab, because at the end of the day, someone has to pay for it. And that's what we should be aiming at. But, but then, of course, the issue of do we have adequate infrastructure so that whoever needs to be treated can be treated in their county? That also has to be addressed, because a patient may have to make a very long journey, even if the treatment was availed free. And you have to make a trip to Kenyatta National Hospital for radiotherapy. For some patients, that trip alone, even if the treatment is free, you are coming, all the way from Kapenguria or from some place, you might decide, you know what, I'm not going to make a trip to a city and I don't have a place to stay.
To sleep, yeah. Yeah, it's a whole different journey.
Yeah.
All right. Anastasia, in your treatment, how many sessions have you left, or you're done?
No, I'm left with one.
With one?
Yes.
All right. In terms of your diet, was there any advice that you were given by the doctor in terms of what to eat, even as you undergo this chemotherapy?
Yes, I was told to eat a lot of natural foods like vegetables, a lot of fruits, to avoid the red meats. But the foods also are very expensive. To get these natural foods is not easy. Yes, and to drink a lot of water. I have to avoid these sugars, a lot of sugar. Yes.
All right. So just picking up, from what you're saying in terms of there are a lot of myths and misconceptions out there regarding what you should eat and what you shouldn't eat. Perhaps you can guide us on what are some of the foods that perhaps we should focus on, specific foods that perhaps could lower the risk of getting specific cancers.
Okay. I will put it in very simple and basic terms. A balanced, healthy diet. Okay. When I'm talking about a balanced, healthy diet, I'm talking about a diet that is that includes fruits, vegetables. We're talking about high fiber diet. Okay. Low fat diet. We're talking about things like lean red meat that is unprocessed. Okay. White meat is also good. Okay. Plenty of water, like she says, and lots of natural foods. The problem is we've tried to adopt the Western lifestyle, and that could be the reason why the incidence is the fast foods, and that could be the reason why the cancer is on the increase. But if we stick to our traditional foods, then I think we will be safe. Okay, so I'll put it very simple and basic: balanced, healthy diet, traditional. Okay.
There's always been the argument: is cancer on the increase, or we are just now becoming more aware of what is happening around us?
I would actually say cancer is on the increase. Yeah, like from the figures that she has projected, that is from the estimates from the GlobalCan 2018 data sheet.
Yeah.
Actually, currently, or rather as at 2018, we recorded around 47,887 new cancer cases. And we had around 32,987 dying from the disease. Those were figures from the 2018 data sheet. So this mortality figure translates to a figure of around 90 people dying of cancer on a daily basis. Actually, quite a huge impact, both economically and socially. So I would say that yes, cancer is on the increase, partly maybe because of the lifestyle changes we're talking about. People are smoking more, people are taking a lot of alcohol, there's a lot of sedentary lifestyle, people are not exercising, or there's leading to obesity. Then there's also the aspect of diet, like we speak, okay, like we said earlier. So all this could be contributing to the increase in the cancer burden. Then number two, it could be attributed to the improved diagnostic facilities. We are able to diagnose cancer. We have the imaging and even pathological tissue analysis. Now we are able to diagnose cancer more in a better way. So these two aspects could be the reason why we are having the increase in number of cancer cases. But all in all, I would say yes, there's an increase in the number of cancer cases.
An increase in the number of cancer cases. All right, we're having a discussion on cancer, the burden of cancer in our country, and we're just focusing on some of the preventive ways that you can be able to cushion yourself from getting cancer, and just understanding issues around treatment, given that we have Anastasia Otieno, who is currently a cancer survivor battling colorectal cancer. And we now want to hear from you, so I will be crossing over to Jane, who is on the other side of the studio, to give us your feedback. Jane?
Yes, Catherine, let me just go straight to it. Remember, the hashtag is hashtag BTH. There is one Hafulu Imboko who is saying, we have only two options, medically and emotionally. Give up or fight like hell because cancer is real. Hagono is saying, let me just quickly get that. Hagono is saying only the rich can afford cancer treatment here in Kenya. The poor sadly face a certain death in the fight against cancer here in Kenya. We have Cancer Soldier who is saying we should have a discussion on childhood cancers here in Kenya and also educate the patients on the importance of water during chemo. All right. Let me get another one from Joram who is saying one major problem with the whole issue of cancer is the lack of commitment by the government to handle this matter with the seriousness that it so deserves. Sadly, most of the burden is felt by the poor here in Kenya. We have Kipsang Kituru who says from Mombasa, we need to focus on checking our lifestyles. Let's go to traditional foods and let's condemn cancer with one voice. Justin Bitang is saying this discussion has assisted so much when it comes to cancer, but we should stop this narrative of screening. We want the discussion on primary preventative measures. What more do we need to do? He's saying the guy has spoken so well. That is Justin from Kisii. Selfmade is saying, colorectal cancer screening can reduce death risk by at least 90%, yet only 1 in 3 adults aged between 50 and 75 have gotten screened as recommended. Awareness levels are still very wanting. As you can see at Chianga, the whole issue of awareness levels and, having this regular screening done to just help be more on a preventative sort of approach as opposed to a reactive way of looking at it. Somebody here asking about the measures again. Kipsang saying we need to change our lifestyles and go back to the traditional foods. Joram saying the commitment from the government is not as serious as it ought to be. And let me quickly see Cancer Soldier saying we need to also focus on childhood cancer. And finally, Hagono saying, only the rich can afford cancer treatment here in Kenya. Is it true? Is it not true? Is that the narrative that is being projected when it comes to the fight against cancer here in Kenya? Back to you, Catherine.
Well, thank you, Jean. Of course, we appreciate you giving us your feedback. And I want to begin from, one of the comments about cancer becoming, part of primary healthcare. Should we go in that direction or are we already there?
We should have gone that way maybe 20 years ago, and maybe if we had done that 20 years ago, probably we would not be in this sort of crisis as it were, because we'll be focusing on prevention, not just for cancer, but for non-communicable diseases. Remember, most of the risk factors are shared. So if, for example, tobacco use won't give you cancer, it's probably going to give you heart and blood vessel disease, what we call cardiovascular diseases or other problems. So if we were addressing those sort of issues at primary level, mashinani, prevention, and we would like to hear this even from our governors, our MPs, our MCAs. When they stand to speak, tell wananchi about the prevention measures that they can do, because everyone can do something about cancer, especially when it comes to prevention. There are individual responsibilities that we must undertake. And I must mention something about the diet, maybe to add on onto that. Let's also remember that there's no one type of food that will prevent you from getting cancer. And there's no one type of food that will cure cancer. Food doesn't cure cancer. And those are the sort of things you are seeing on social media. You need to wake up and take a lemon, one glass of lemon and something that will cure cancer. None of that is at least scientifically sound in terms of the evidence that we have. So that should be very, very clear. But in terms of prevention, there are also policy and legislative issues that can be addressed by county governments. Enact stringent tobacco control measures at county level. Enact policies that promote physical activity, deliberate. Have that incorporated within the school system. Many of us went to school in the days when you had double PE lessons, physical activity.
And these days they don't even exist in the time.
These days you have schools that don't even have a playground. They don't even have a playground where kids can actually do their PE. Let's make it deliberate. When we tell Kenyans to walk For example, you know, in Nairobi, I think this past year when somebody said matatus shouldn't get to the city center once a week and Kenyans should walk. I mean, there was such uproar because we didn't use a public health approach. I'm sure if we talked to Kenyans, people would be happy to walk, you know, at least a stage or two before they get to their office, but they need to understand the value of physical activity. You don't need to invest in a gym. So these are things that we can do as a country. They are low-hanging. They are not financially intensive. So we can incorporate within the school system, in colleges, and get people healthy.
Okay. Just picking up, you know, from what you said, the issue about, you know, the taking water to, you know, with lemon to try and fight cancer. It brings us back to the question of, there are also those myths of, you know, people who say that you can be able to starve the cancer cells in your body. Perhaps, or what would you tell Kenyans in terms of, are these things feasible, and, you know, what are some of the things that they should just stay away from? They're just not practical.
So just before I answer your question, maybe I'd like to sum up what he was trying to say. Now, when it comes to prevention, basically it starts with you, okay? It starts with you. So basically what I'd like to say, maybe a bit of a few points. One, let's improve on our health-seeking habit, okay? In terms of let's do our annual checkups, okay? Let's do our annual checkups because anything abnormal can be detected and appropriate interventions instituted. Number two, let's stop smoking. Number three, let's reduce our alcohol intake. Number four, the physical inactivity I was talking about. Let's exercise because this helps to reduce the cancer risk. Then last but not least, the aspect of diet. Let's eat a healthy, balanced diet. So those 5 things are some of the things we can do at prevention level to help in cancer prevention. Now, when it comes to cancer starvation, cancer cell, starving yourself so that the cancer cells do not grow.
They die.
That's probably just a myth.
Because
like
of the argument that if you take in sugar, you know, it feeds, the cancer cells feed off it.
No. That's probably just a myth. There's no scientifically proven evidence to show that that is correct. So, no, that is not true. Yes.
All right.
You also hear people talking of something alkaline. And,
like you make your body alkaline for,
I mean, those are all really myths, and there are things that we need to debunk. In fact, the best way to start doing that is if it comes to your WhatsApp group, don't forward it because you're perpetuating that. Let's get people just eating healthy and avoiding all these processed fast foods.
Exactly.
Just get back, you know, ongeza mboga na matunda, punguza nyama.
Exactly.
You know, simple message.
Okay. All right, Anastasia, based on, you know, the challenges that you have gone through in your treatment, perhaps what is it that you would want the government to do differently to allow persons detected with cancer to be able to go through this process easier?
I think the government should act, and they should act very fast. They should not wait for some 2 or 3 prominent people to die, or the rich people before they act, because many Kenyans are dying of cancer. Yes, they should act and act very fast.
In terms of the challenges that you would want them to address, what would you, you know, point out first?
They should reduce the cost of treatment for people like us, you know, people from slums, because this cancer is very expensive for us. Sometimes we, like for example, me, I used to miss chemo when I don't have funds to go to for my treatment, and it is not a good thing to do. You should not miss your medication. Yes, so they should reduce cost so that many Kenyans can afford the treatment.
In terms of support for the diet, is there a way that perhaps you'd want them to also incorporate it, just like we see, you know, with HIV and AIDS drugs? They also have you know, an aspect of nutrition.
Yes, they should provide diet for cancer patients. Yes, also. It is very important, especially during chemo and after chemotherapy, because the treatment we undergo is not easy.
All right. Let's talk about, you know, after care. Do many people really go through that process in terms of even the psychological, how a family should behave, change of, you know, because you're talking about a change of lifestyle for the whole family when perhaps 1 or 2 people is diagnosed with cancer?
Sorry?
Do we prepare, you know, families on how to cope with cancer once someone within the family, you know, is found to have cancer? Do we prepare them for that lifestyle change, the psychological bit of it as well?
Okay. Ideally, the proper approach is what we call a holistic approach to cancer patient. So you do not only treat the patient, you also try and counsel the relatives. You speak to the relatives, you speak to whoever involved in the care of this patient. We do not only focus on treatment of the cancer patient alone, no. So ideally, you counsel them on the diagnosis, you inform them of what changes are going to happen, either socially or economically. You have to communicate all this information to the family comprehensively so that they are aware, because you see, most of these cancer patients and most of this cancer treatment usually has to take place for a very long period of time. Let's say a minimum of 6 months. For the person who will undergo the shortest period of treatment, maybe 6 months, you see. So you see, this 6 months is going to be a very life-changing period for the patient and for the family as a whole, okay? So I think it is good not to just focus on the patient. Let's also pay special attention to the people who are involved in the care of the patient in terms of family support, emotional support. You know, we need to like involve them so that they are aware of what all this treatment process entails. Yeah.
All right. So our time is almost up, but I want to ask you, David, do you think the government should declare cancer a national disaster as we sum up the program?
Yeah.
Based on what we've discussed this whole time and the issues around it.
I think over the past 2 weeks, that has been the refrain from many Kenyans, and I know the Cabinet Secretary for Health, Sisiri, did pronounce the position of the ministry, and I mean, one would want to look at cancer also in the context of the non-communicable diseases. Yes. Cancer is the third largest killer, infectious diseases and cardiovascular and cancer. Cardiovascular probably has twice as many people that mortality and morbidity as cancer, So one would want to look at that in context, to say then, would we be addressing one problem while leaving all the other big problems within the healthcare system? Yes. Remember, many of the risk factors are shared. Probably if we are looking at anything, then we should be looking at non-communicable diseases. Okay. Let's address them decisively. If it takes us to declare them the entire spectrum, a disaster, so be it. But then we need to make sure we have the infrastructure in place, because even if we do that today and pronounce ourselves, and we don't have the relevant infrastructure, human resources, we've not sorted the issues of costs. Those things have to be done decisively. I can tell you for sure, if we sort out the issues of access and costs, like you can go with your NHIF card and get your treatment, screening, lab test, everything free. Nobody would even be saying about the disaster, because all we need is Kenyans need to access treatment without having to be made more poorer than they already are.
Okay.
So to just add on to what he's saying.
That should be your last comment as well.
Yes, sure. So to just add on to what he's saying, I would want to say that as a country currently we are not hopeless. We have made progress with regards to human resource, equipment, infrastructure, and even financing in response to the cancer burden. Progress has also been made in trying to enhance access to these cancer services. Of course, this has been guided by a clear policy and legal framework. So in my opinion, I think the situation is not insurmountable. And it doesn't warrant declaration of the current cancer burden as a national disaster. Okay. All what we need to do, or rather what is required, is just investing in a little more funds in order to upscale things like awareness creation, screening and early detection, like we are saying, to strengthen our diagnostic services, to improve on the treatment services, and of course, finally, proper preventive interventions need to be addressed as well.
Okay. Yeah. Thank you. Anastasia, thank you for sharing your story with us. It's a story of hope to see you here and, talking about it, raising awareness. That is, thank you very much for sharing your story with us. So I'll just give you 30 seconds to look into the camera and just give hope to, other people who are also battling cancer as we speak. Just 30 seconds. Your camera is straight on.
Thank you. To those who are battling cancer, I know it is not easy. You should also involve God in fighting this disease, because tunaona wenye wako na pesa pia wanaenda, wenye hawana pesa wanaenda. Sasa tujiachilie tu kwa mikono ya Mungu. Yes.
All right. Thank you very much, Anastasia. Of course, that is Anastasia Otieno. She is a cancer survivor currently on treatment. She has colorectal, I don't know why I keep mispronouncing it, yes, cancer, but of course hers is a story of hope. The journey still continues. We were also talking to Dr. Sibylle Smith, who is a clinical oncologist. Thank you for coming this evening. And finally, David Makumi, who is the vice chair of the Non-Communicable Diseases Alliance. This is where we put a cap on Beyond the Headlines. My name is Catherine Achenga. Let me quickly hand you over to Jane to take your final feedback before we wrap up the show completely. Over to you, Jane.
Actually, we're just going to put a cap on today's discussion right there. But thank you so much for being part of this journey. We do hope you have learned a thing or two from this discussion when it comes to the conversation around cancer. Be sure to join us again next week right here on KBC Channel for another fantastic discussion right here on Beyond the Headlines. My name is Jerome Boy. Do enjoy the rest of your viewing. Darubini is up next.
Yakabi, go away. She's not here.
Leave the farm.
What are you talking about?
Pack your bags and leave. And follow that Njoki that you so much admire.
Oh, come on, baby. All work and no play is not good for you.
Oh, work and no play? Look around you, you little selfish girl.
Selfish?
Yes, selfish. All my wives are gone. The farm is falling apart, but all you think about is having a good time. Why did chaos begin suddenly when you arrived? The farmers lost money, but I was too busy with you to see it.
Hello.
Are you ready for some infotainment?
Right.